About Achilles tendon ruptures.
Yes.
Achilles tendon ruptures are common. The incidence has increased during the last years, probably because of that the people continue to be active in the later years. The highest incidence occurs between 30 and 40 years, but there is a second peak in elderly non-athletes. Male-female ratio ranging between 5 to 1, and the most common subcutaneous rupture, 2 to 6 centimeter proximal of the insertion, is the most common. Diagnosis is based on medical history, clinical examination, and there is no necessary for using ultrasound or MRI, for example. 60 to 90% occur during sports activity, whereof racket sport dominates. There are two main theories about the etiology, degenerative and the mechanical. Healing process also need mechanical loading and mobilization, as shown in recent published studies. Treatment is still controversial. Surgical or non-surgical, cast or orthosis, early mobilization. Well, although there are around 20 randomized control studies, we have no answer yet. There are also systematic reviews, up to 6, and they are comparing the surgical and non-surgical treatments, and in middle there are around 4 to 13% of re-ruptures when comparing surgical and non-surgical treatment. They also look at the infections, delayed wound healing, DVT, and nerve disturbances. So how should we treat the patients? Well, the surgical treatment, the most common to use, is the end-to-end suture, and it's not necessary with augmentation if it's an acute rupture. The percutaneous technique, the most common used, is the one described at 1977 by May and Griffith. When talking about non-surgical treatment, Nister described in the first randomized control study in 1981, where the non-surgical group were treated 4 weeks in equinus position and 4 in neutral position. This treatment has been common to use and is still doing. But there are other studies that are talking about functional brace, that it should be better to use. And you could reduce the re-rupture frequency, as Seller showed in 1992, the first randomized study. Complications. Re-ruptures has always been the most common endpoint, but other is wound infection, adherence, nerve injury, and also tendon elongation that we are going to hear more about when Karin is talking. I would also talk about our study from Gothenburg, where 97 patients out of 100 were randomized to surgical or non-surgical treatment. Both groups have a cast in 2 weeks in equinus position, and then a functional brace for further 6 weeks. They were only allowed to partial weight bearing. Primary endpoint was re-ruptures, and the results show a re-rupture frequency of 4% in the surgical group and 12% in the non-surgical group. And we also used the patient-reported instrument, the Achilles tendon total rupture score, and when we used that, we couldn't see any differences between the groups. Functional tests using the muscle lab system showed a difference between the groups after 6 months, but after 12 months there were only in one functional test differences, the so-called heel rise work test.